Hi, everybody. I'm Rosie Hogg from Belfast in Northern Ireland, and it's great to be with you all today on this third World Day of Regional Anaesthesia and Pain Medicine. So, I'm going to spend a little bit of time with you talking about some point of care ultrasound papers that you may have missed in 2025. So, even if you're an experienced user of point of care ultrasound or you've never done anything at all to use this in your clinical practice, I'm hoping that these four papers will give you a taste of why I think point of care ultrasound is so important in our day to day clinical practice. We haven't got a lot of time, so let's get started. So, the first paper I have for you is this one. So, it's a single center study of 72 parturients, and this was in IJOA last year in 2025. And what it was looking at was the number of patients that you can get really good images for clinical decision making, not just using the phased array transducer, which is what we commonly use for cardiac point of care ultrasound, but actually using a curvilinear probe. So something that you would have on your obstetric unit all the time that the obstetricians would be using. And why is this important? It's because many of our sites don't have a phased array probe to use, particularly in obstetrics. But as patients are getting older, they're getting larger, they may have other cardiovascular comorbidities. It's really important that we can do cardiac POCUS on these patients as and when we need to. So other secondary outcomes in this study looked at the comparison of the 5 point of care ultrasound views that we use in cardiac focus. So this is focused ultrasound, trying to get these 5 images and getting yes, no answers to questions. And as you can see here, you can actually get some really nice views using the curvilinear transducer. And we often think this isn't possible because it's got a larger footprint. But this study showed that you can actually get some good views, of course, dependent on the patient. So what was found here? So looking at these individual cardiac views, they were really looking for non-inferiority, in particular which views were easier to get than others. And throughout this study, what was shown, and these were in residents who didn't have a lot of cardiac ultrasound experience, is that in certain views, particularly the parasternal views, using a curvilinear transducer was actually non-inferior to using a phased array transducer. But this was particularly in those parasternal views. And I just want to highlight that actually in the apical and subcostal 4 chambers, the views weren't as easy to obtain. And you can imagine, particularly in that subcostal view, it's going to be difficult in a pregnant patient. And again, in the inferior vena cava view, there really wasn't a non-inferiority established there. But what about measurements? Because we quite often like to measure in cardiac POCUS as well. And actually, in quite a few of the images that were obtained by these people who didn't have a lot of cardiac POCUS experience, you were able to get some good measurements, but only if you got the view. So in particular patients that you were able to get a good view with the curvilinear probe, you were able to do a number of different measurements. And this is going to be really, really important for if you've got a patient on the labour ward who's particularly unwell. So what's our key takeaway from this study is that anesthesiologists with limited experience in cardiac echo can actually achieve clinically useful focus assessment in over 90% of parturients using a curvilinear transducer, but this is particularly in the parasternal views. So this is a great study to show that even if you don't have a phased array transducer on your obstetric ward, you can, in many patients, able to achieve maybe 1 or 2 views to give you that extra clinical information. But again, for measurements or obtaining other views, a phased array probe is recommended. And I would say that if you can get another probe for your labour ward, definitely get a phased array probe. So this is a bit of a whistle-stop tour through some of these papers, but it's just really to give you a little highlight as to what's out there in the POCUS world at the minute. So here's another study, and I thought this was really interesting because it was looking at the prevalence of ghost scans in point of care ultrasound for trauma patients. So you might be wondering, what's a ghost scan? So a ghost scan is whenever you scan your patient and do your POCUS assessment, but you don't record that assessment anywhere whatsoever. So this looked at 4 level 1 trauma centres across the Northeast USA, and it was a retrospective chart review of over 6,000 patients. And as you can see here, there were 4 different sites, all of which had a similar number of site visits every year, but some did a lot more POCUS with 20,000 POCUS examinations per year, but all of them did a significant amount, with the lowest just being 7,500. And again, these are sites that have emergency resident programs to be able to train in POCUS as well. So what did they find? Well, the really interesting thing in this study was the variation across the number of sites. So these were the percentage of ghost scans and the difference between if there was blunt trauma or penetrating trauma. And again, if when they were doing the scan they were doing here in particular was the fast scanning. So that's looking at a number of different areas to see whether there's blood in the abdomen or free fluid. So you're looking particularly around the liver, the spleen, the bladder. And again, it's the variation across the sites that's really, really interesting here. And one of the things that came out was why there was the variation across these sites, or sort of thinking about why it was. So at site one, they required a specific login. So this can be difficult to access that, especially if you're in a hurry in a trauma situation. At site two, where you can see there was a lot of ghost scans, there was no POCUS image manager. So that meant it wasn't very easy to link between the electronic medical record and the POCUS scans that you're taking. In site three, which you can see had the lowest number of ghost scans, there had been a quality improvement initiative here to try and reduce the number of ghost scans. So there was regular emails sent around to remind people. And also there had been a yearly review of how many of your scans you hadn't uploaded to the system. So it's simple things like this, which are really good. And what was really interesting at site four, where there was a huge percentage of ghost scans, one of the biggest problems here is that there were lots and lots of different people recording scans. So there were trauma residents and surgical residents and ED residents. And again, there wasn't that sort of consistency and the sort of culture of reporting. So why does this matter? Does it matter when we take a scan if we don't record? Because many of us, when we're doing nerve blocks or doing POCUS, we don't always record our scans. But sort of going forward from here on in, I think it's really important that you do record your scans. And the reason for that is that it's got actual implications for patient care, because if you've done a scan and then you want to review again and you haven't got the previous scan, you've nothing to compare it to. And in many countries, you're going to lose your billing opportunities because you can bill for the POCUS scan, or you can actually add to your department's kudos and things by doing this sort of thing. And if you can't produce those scans, you're going to lose those opportunities. And I think most importantly as well, you may increase your medical legal risk, because if you've made a decision based on one of these scans and you've got nothing to prove it, it's going to be really difficult to stand up to that. So the key takeaway from this is record all of your POCUS scans, be it ideally to your electronic medical record, or record them somewhere anonymously, but be able to link to the patient. So here's another study that came out in 2025 that you may have missed, which I think is a really interesting one. So again, it's looking at cardiopulmonary point of care ultrasound. So this is using both cardiac and lung POCUS to be able to make a differential diagnosis in patients who've arrived to the hospital with shortness of breath. So what I thought was really interesting about this study is the primary outcome was actual hospital length of stay, which is really important for both patients and for the hospital system itself. And secondary outcomes were total direct hospitalization costs. And of course, this will depend where you are in the world. But again, length of stay for patients, getting patients up and going and getting them home again is really, really important if you ask a patient what their patient-centered outcome would be. So this is a large single US tertiary center, and there was 5 internal medicine teaching teams. What was interesting about this study is that the images were reviewed by cardiologists, and the scans were done by a team of people who were quite well trained in POCUS. And I think this is one of the really interesting things. But what did it show? So there were about 208 participants in total. And as you can see from this, they're fairly similar in the groups. And they had a number of different cardiac conditions, a number of different comorbidities, but they were quite similar across both of the groups. So these are patients just presenting to the hospital needing treatment for undifferentiated shortness of breath. And what came from this study? Well, the thing that was really interesting for me was that there was an over 30% reduction in the expected length of stay when using POCUS, which is kind of a crazy number, isn't it? Because it reduced the mean length of stay from almost 12 days in the control group to just over 8 days in the POCUS group. So that is a massive difference to not just your hospital, not just to the system. In many places we're struggling with beds, we're struggling with getting patients admitted to the hospital. But there's 246 hospital bed days saved overall in this small group. But again, there was no increase in 30 or 90-day readmissions, with a direct savings cost of over $750,000. So this is applicable across the world to any site that you're working on. And the main thing from this is, I think, it's that you're getting the diagnosis really, really quickly, and you're able to treat that patient. You know exactly what's wrong with them. You know if it's heart failure, if it's a pneumonia, you're able to diagnose that really quickly. But not just that, you're able to treat and then rescan again. And that's what's really, really interesting about point of care ultrasound. So the key takeaway from this is that POCUS is associated with a shorter length of stay and lower costs. But again, they really highlighted the need for more training and integration, because there was only about 20% of the hospitalists in this particular hospital that were able to do POCUS to this level. So what we really need to do is focus on training and integration in clinical practice, because we've seen again and again from these papers that there's a definite improvement in patient-centered outcomes. So I don't have a lot of time to spend with you today. Honestly, we could have spoken about 20 different really interesting papers, but I just want to highlight one more paper that's really, really critical that came out last year in RAPIM. And this is from Stephen Haskins and many other fantastic POCUS enthusiasts across in the US. And this was the ASRA PMED's narrative review on gastric point of care ultrasound in more complicated patients to assess aspiration risk. So gastric ultrasound is about the most exciting thing of point of care ultrasound at the minute. With all the GLP-1 agonists and patients getting more challenging, it's really, really important that everybody is able to do this very straightforward technique to be able to assess whether a patient has got any residual gastric contents and assess their aspiration risk. So this narrative review looked at assessing the gastric contents in the highest risk patients, sort of medically complex patients. And this is just a quick infographic, and it showed that there's really good support for doing gastric point of care ultrasound in diabetic patients and patients that are in active labor. So there's lots and lots of evidence to say that it's really important that we should be doing gastric POCUS in these patients, because there is a risk of a higher increased risk of residual gastric contents. There was, interestingly, conditional support for patients who are taking GLP-1 receptor agonists, even though we're seeing lots and lots and lots of papers and lots of discussion about this. And that's really just because the evidence isn't there yet. And again, for obesity, emergency surgery, or patients who've got NG tubes. And I think the conditional support part of this is really just reflects the lack of evidence. And gastric ultrasound is something that we really need to be doing more and more studies in. The problem is, obviously, because aspiration is such a rare event, you would need to review millions of patients to be able to see whether a gastric ultrasound reduces the risk of aspiration. But what it really does for me, it gives me a patient by patient personalized assessment of their gastric contents. And honestly, once you start doing gastric ultrasound and you see that patient, particularly the patient who's coming in for emergency surgery or the patient who's taking a GLP-1 receptor agonist, and you see those increased residual gastric contents, you'll want to do it on so many of your patients. And this paper particularly supports doing it in a number of different patients. So again, gastric ultrasound is rapidly becoming an essential tool for patient assessment and clinical decision-making, particularly in these higher risk patients. So thank you for listening today. That was very much a whistle-stop tour through some of the most interesting papers that I've seen in the last year. I've added the QR code so you can go and read these papers yourself. But I'm really glad that you've joined us today for this World Day of Regional Anesthesia and Pain Medicine. It's wonderful to have so many people from across the world. And I'm really glad that you're all so interested in point of care ultrasound. And you're going to hear a little bit more about our first ESRA point of care ultrasound course. But look all around the world, there's lots of point of care ultrasound training going on everywhere, and make sure you use it as much as possible. Thank you.